Hi, everybody. Welcome to chapter 24. We're doing the urinary system. We're going to start with urinary system anatomy, and then we're going to spend some time with urinary system physiology. So let's go ahead and begin. Well, it helps if you get the slideshow going. And you'll notice I'm in a different place today. That is because I'm in the AP1 lab. I was filming between teaching, so you get to enjoy some different scenery, and you can be very glad that you are done with AP1 and don't have to be here. All right. The overview of the urinary system, there's several major organs. So these organs are the kidneys here. You've got your ureters, which carry the urine, and then it goes to the urinary bladder. And then the urine leaves the urinary bladder and the body through the urethra. The adrenal gland, that's on top of the kidneys, looking like their little hat, and it's showing you in relation to some of the larger vessels where these ureters are located. There's several main functions. So the urinary system is going to help adjust blood volume and blood pressure levels. It's going to regulate blood plasma concentrations of sodium, potassium, chloride, and hydrogen ions because it is important to stabilize blood pH. It's going to conserve nutrients by reducing their loss in urine. And then it's also one way that we can remove toxins and drugs from the bloodstream. And I think you'll find no matter what field you are in medicine, the kidneys follow you there, whether it's figuring out if your drug's going to be metabolized, if it's managing blood pressure, blood volume, or if it's making sure you're not giving too much or too little fluids. It shows up a lot of places. So let's look at the ureters first. There is one ureter that goes from each kidney to the bladder. So that means there's two ureters, and they are lined with a transitional epithelium, which is the same in the bladder. So these ureters, they have an outer connective tissue layer. Here, they've got a smooth muscle layer, so muscularis. They have a mucosa, which has a lamina propria. Remember, we always need that areolar tissue to help support the epithelial tissue. And this epithelial tissue is transitional epithelium. Transitional because it changes shape. And if you'll notice, there's quite a bit of cytoplasm around some of these nuclei. And these cells are known specifically as umbrella cells, and they are part of what allow for that stretch. So your ureter does stretch to an extent, which is good because if you have a stone in the kidneys, sometimes it can pass through that ureter and get to the urinary bladder, and then potentially it can pass from the body. However, sometimes the stones get stuck, and then we start to have more medical issues. So the ureters, here they are draining into the urinary bladder. It is where we store the urine. It has rugae like the stomach. So you can see here those rugae that are present. And surgically, when you open the bladder, it is mostly, you see mostly folds when it is small. When it's large, those folds disappear as it is stretched. So it has that unique transitional epithelium, which can expand and thin out, but it is still waterproof. So things don't get through those gaps. And then you can see here the ureters actually run posterior to the bladder, and they open here at these ureteric orifices. And these are slits instead of round in shape, and that helps prevent backflow to the kidneys. And while in humans, it seems like a little strange that you would have the ureters drain more inferior in the bladder. In animal positioning, these ureter, when you're a quadruped, so walking on 4 feet, these ureters drain from dorsal to ventral. So they are actually, this would be the top part of the bladder. So you wouldn't be getting as much backflow. But either way, that slit shape covers things for us. So a few things to be aware of. We have the detrusor muscle. This is the muscle that surrounds the bladder and what allows us to squeeze the bladder and empty it. This muscle, you can have issues where it's gotten so stretched out, it's not really working and you're having trouble either storing urine or releasing it appropriately. But that's our detrusor muscle. You have some ligaments. You you have both two lateral umbilical ligaments and a middle umbilical ligament. And these are related to formation in utero. And they're helping support the bladder right now, but there are more remnants of what was there. This particular area of the bladder, inferior, is known as the trigone. It has a special name at that point. And you can see the neck is where the urine will exit the bladder into the urethra. Here is our bladder tissue. So you can see that little thin layer of visceral peritoneum that covers this organ. The bladder is within the peritoneal cavity. You've got this detrusor muscle, and this muscle will be thicker or thinner depending on how much the bladder is stretched out. You've got your submucosal layer, and the bladder, it too is the holding layer if you're ever doing surgery there. And then the mucosa, you've got your lamina propria as supportive tissue, and then that transitional epithelium that is able to stretch and accommodate more amounts of urine. So the urethra is how urine is transported out of the body. In the males, if we look, here is our urinary bladder, here is our urethra, and the urethra actually passes through the prostate before becoming the penile urethra. In the females, the urethra is anterior to the vaginal canal. And you can see here is the uterus and the vaginal opening, and you can see why if there was a child in the uterus or a fetus, that would definitely push on the urinary bladder and could cause some urgency and need to go. It would make you feel like you have to go all the time, which is why pregnant women are often going frequently. You can again see here's the ureters coming down from more superiorly where those kidneys are. So micturition, that is the name for the process of urination, micturition. And there are two spinal reflexes that are involved. So the first is in the pontine storage center, and that's going to inhibit urination. This happens under sympathetic control. So again, I always think with my sympathetic system, if I am running from a bear, do I want to be peeing myself or not? And the answer is I do not. So the sympathetic system is going to inhibit urination. And then you have the pontine micturition center, which stimulates urination, and that is under parasympathetic control. You want to be relaxed and safe before you urinate. Both of these are located in the brainstem, so very specifically the pons, and the pons has a lot of those autonomic nervous centers there. So it makes sense the location of these urination centers and reflexes. A couple of terms to be aware of. These are huge terms, so make sure that you know them. Polyuria means excessively urinating. So you can see polyuria in diseases like diabetes mellitus, but we'll talk about diabetes insipidus as well. You can see it in diseases where you might have excessive corticosteroids like prednisone. And when I say excessively urinating, even more than that, it's excessive urine production, so more than usual. You have anuria, which is not urinating, or urinating less than 50 milliliters per day. And anuria is a big problem because it either means you are severely dehydrated, so dehydrated that you have no fluid you can lose, or your kidneys are not doing the job at all, and you're not able to pass enough through the kidneys to even build up a store of urine in the bladder. Incontinence is you're having normal production, but you're not able to control it. So that's things like leaking urine or not realizing when you're urinating or not being able to control the urination. And dysuria, it means that urination is painful. And so that can happen with things like urinary tract infections where you may have painful urination. If you've noticed a theme, we have the suffix of uria when things are having to do with the urinary system, and there's a prefix of nephra, like nephrons or nephrology, that will also follow through this unit. So we've talked about how the urine's going to get out of the body, but we haven't talked about where does it come from. And it's made in the kidneys. So these kidneys, they are retroperitoneal. So they're behind that parietal peritoneum. They're there with the pancreas and part of the colon. They are located on either side of the vertebral column. Notice that the right kidney here is a little bit more inferior than the left kidney. Sometimes those are good things to be aware of in your patients. You can see there is what's known as the hilum, and the hilum is where the renal artery, the renal vein, and the renal nerves enter, and where the ureter leaves as well. So your hilum is kind of the location where all of these come into the kidney. They have a fibrous capsule made of collagen fibers around them, and we'll see that on our histologic views. And there are two outer layers. So, outside of that capsule, you've got some perinephric fat. So that's essentially fat around the kidneys. And then you also have some renal fascia as well in that area. Really interesting that different animals have different shapes of kidneys. I find it really interesting. Some horse kidneys are more heart-shaped, and especially cow kidneys are lobulated, so kind of lumpy bumpy on the surface normally. So if you ever are at the grocery store and you can see that they're selling some kidneys in the meat department, it's kind of neat to see because you can see that perinephric fat around them as well as the change in shape by species. It is possible to be born, but going back, it is possible to be born with only one kidney, and it is possible to survive with only one kidney. That's how we have kidney transplants. You can be a kidney donor and you'll still have what you need. It just means you have to take care of that one kidney because if something happens to it, you don't have any backup. And good to know that the fat helps protect these kidneys because they're not fully encased by bone. The inferior half is not covered, so you've got a little bit of fat around them to cover them in that spot. So here is some gross anatomy of the kidney and some terminology. We have our renal cortex, that is our superficial layer that goes along the outside of the kidney. And then the inner region is called the renal medulla. And these have a very distinct appearance both grossly when you're looking at specimens as well as on ultrasound. You can tell a lot about it. Notice that you've got your fibrous capsule, which is on the outside of everything. And your renal pyramid, or excuse me, your renal medulla has a couple of divisions in it. So you have these sections of renal pyramids that look like little triangles. And then between those renal pyramids, you have renal columns that run between them. And you have, these can be further subdivided into renal lobes. So a renal lobe is one half of a column, a full pyramid, the other half of a column, and the cortex. And there's usually 6 to 8 lobes in a kidney. There is a system for draining the urine from the renal medulla down these tracts. And so we're going to see right here where these renal pyramids end. Those are our renal papilla. They are going to drain into what's known as a minor calyx. That's CALYX. And then they'll drain into a major calyx and then into the renal pelvis. And the renal pelvis is where that will all build up before it is released through the ureter. If you have an obstruction in your ureter, then sometimes the fluid backs up into this renal pelvis, and you can see on ultrasound that the renal pelvis gets huge. If you have kidney infection, sometimes it's not just urine that's in that renal pelvis, but it is also pus from the degree of infection. So that's one of the things that you check out on an ultrasound to see, is that pelvis the normal size or is it excessive in size, telling us something's not draining. A little bit more terminology. So we're seeing here is a actual preserved specimen. You can see the capsule around with your cortex outer layer and your renal medulla inner layer. Here are your columns, your renal columns. Here is a renal pyramid, and here is a renal papilla. And so a minor calyx is defined as something that drains only one lobe, while a major calyx drains several minor calyces. And then there is our renal pelvis, where the urine is going to collect, and we're labeling this area as the hilum. Not only does the ureter come out of that spot, but the blood vessels and nerves and veins and arteries will also enter and exit from there as well. So that is the gross anatomy. Let's see what's going on microscopically. So the functional unit of a nephron, the smallest unit that does the jobs that it needs to do, is the nephron. The functional unit of the kidney is the nephron. Spoiler alert, I got too excited to tell you. And there are two types of nephrons. So the first type is a cortical nephron, and that is most of our nephrons. And these are really just in the cortex. You can see here the thin and thick loop may dip into the renal medulla, but most of it is in the cortex before it drains to that renal papilla. You also have these juxtamedullary nephrons, and these are really important to keeping urine concentrated. So they are actually, most of that loop is in the medulla, and that's going to help conserve water through osmotic gradients. Notice juxtamedullary, this defines nephrons. We're going to talk about juxtamedullary cells in the glomerulus. These are not the same thing. So these are juxtamedullary nephrons here. We're going to talk about some cells when we talk about the glomerulus, a little bit different. And there's not a great microscope picture because it's really hard to get a full nephron in the field of a microscope, because when you're cutting, the nephrons are running in so many different planes. Usually you're just seeing lots of little tubes or little pieces of tubes. You're not actually seeing a full nephron. So that's why we're focusing here on this image, because it is such a challenge to see under the microscope and get a full nephron. So let's talk about the parts of the nephron. There are two main parts. You've got your renal corpuscle, which is followed by your renal tubule. The renal corpuscle is a ball of capillaries, kind of looks a little bit like a meatball, where there is very high pressure, and that high pressure is going to push water and solutes out into the capsular space around them, and that process is known as filtration. It should be protein free. So this is one of the first places where we're controlling what is released in the urine. A normal, healthy renal corpuscle should not have any big gaps in it. The protein should be able to stay in the body. If you're seeing protein in a patient's urine, that's telling you that there is a problem in that glomerulus or in that renal corpuscle, and that needs to be investigated because proteins are being released inappropriately. That membrane and that control has been lost. Following that renal corpuscle, you've got your renal tubule. This receives the filtrate from the corpuscle and then modifies it to form urine. So we go from blood to a filtrate to urine. And then the nephrons are drained by the collecting systems, which deliver urine to the calyces. So those two big parts, the renal corpuscle and the renal tubule. The pressure comes from the difference in diameter between the afferent and efferent arterioles. So afferent arterioles, AFF arterioles, they are taking blood to the renal corpuscle. And those usually have a big diameter, or relatively big. The efferent arterioles, EFF arterioles, are smaller, and so it is harder for blood to leave. So you've got lots of blood coming in, but less blood going out. That creates the pressure that is going to push the filtrate through to that capsular space. I remember afferent and efferent because afferent looks a little bit like affection, and affection, you're going towards something. Efferent looks a little bit like effect, and the effect comes after something. Helps me keep those words straight. So here is our renal corpuscle. We have a glomerular capsule. So they call this a Bowman's capsule. It's frequently likened to a catcher's mitt in appearance, but it's kind of cup-shaped. And then within that, you have your capillary network. So here's that capillary network known as the glomerulus. So please note the glomerulus is the capillary network, and it is surrounded by the glomerular capsule. And that together makes the renal corpuscle. So some terminology to be aware of, they're not interchangeable. We've got simple squamous epithelium in our glomerular capsule. And you can remember we saw that in AP1 lab when you were looking in the very first lab at simple squamous epithelial tissue. There were some images of kidneys and you looked at these simple squamous epithelial cells in that area. These capillaries are fenestrated capillaries, so they have little openings in them. That allows blood to stay in. You're not going to be big enough for red blood cells to exit, but it does give space for the filtrate to be pushed out by that increased pressure. So from there, we're going to go to the proximal convoluted tubule, otherwise known as the PCT. And this is a place for resorption of nutrients from the filtrate. And the filtrate, as it's moved from the renal corpuscle to the renal tubules, we're now going to call it tubular fluid. Important to keep track of here as we go through these parts of the nephron, what order do things go in? What happens? Is it being filtered? Is it being reabsorbed? Is it being secreted? What process is going on there? And then what is the shape of the individual cells? So it's a great opportunity for some sorting cards or a chart, because those are the things you want to be aware of. So it's called the proximal convoluted tubule because it's closer to the glomerulus, which is closer to the blood vessels, which is closer to the heart or the central part of the body. And the kind of nutrients we want to resorb are things like glucose. Normally, if you have a normal glucose level, if your body's controlling it, you should want to keep that glucose in. The proximal convoluted tubule is made of simple cuboidal epithelium tissue, but it does have some little microvilli, and you can see them here, to increase the surface area for absorption, because its primary purpose is to resorb. And then from the proximal convoluted tubule, we're going to go to the nephron loop. And when we looked at the kidneys, remember the nephron loop was that long hairpin loop that would kind of peek into the medulla or actually be mostly located in the medulla. And this is what establishes the osmotic gradient for water resorption. So you have a thin loop, and then that's followed by a thick loop. And the thick and the thin loops have different purposes. So the thin limb, or the thin segment of the nephron loop, is simple squamous epithelium, while the thick limb is simple cuboidal epithelium. And again, these are going to have different functions and different roles to play, so they're going to have different cell shapes. Sometimes this thin segment is known as the descending loop, and the thick segment is known as the ascending loop. And then sometimes this is known as the loop of Henle. So there's some different terminology there to be aware of. If we look in our micrograph image here, look at these really thin descending loops, just simple squamous epithelial tissue, compared to these thick ascending loops of simple cuboidal tissue. And then we're going to talk about the collecting ducts later. So after the nephron loop, we're going to go into the distal convoluted tubule, or the DCT. And this part, we have both resorption and secretion. So it's adjusting that fluid composition. And really that is all that the kidneys are doing, is they are letting some things through, then resorbing them, then secreting a little bit more, then resorbing it, to make sure that the blood is at the appropriate levels of electrolytes, hydration, osmolarity, and pH, and then everything else is excreted. So in this distal convoluted tubule, we still have some simple cuboidal cells. We're resorbing and secreting solutes and water at this stage. So we're moving water around at this stage. So here are the segments of a nephron. Let's take a look at it at a whole. So here is your larger afferent arteriole that brings blood in. Here is your glomerulus, that ball of capillaries, that meatball. And here is your efferent arteriole that leaves. You've got your glomerular capsule, and then there's a space between the glomerulus and the capsule called the capsular space. And the glomerulus, the capsular space are all part of the renal corpuscle. You're going to move from there to your renal tubule, and you have your proximal convoluted tubule first, and it's called convoluted because it is very windy, but it needs to be windy to have the surface area to do all of the resorbing that it needs to do. And this is helpful because it's showing you with the colors exactly what is moving through each area. And we're going to talk about this some more, but it's a good tool to have to see that, okay, solutes are being resorbed or secreted. There's some water resorption. Here we've got the little variable solute resorption or secretion. From the proximal convoluted tubule, we're going to move down to the nephron loop where we have a descending thin limb and an ascending thick limb. There is a little bit here of an ascending thin limb if you do hear that referred to. And then following the nephron loop, we've got the distal convoluted tubule. Here we've got resorption and some active secretion before we move to the next part, which would be the collecting duct. This nephron loop is sometimes referred to as the loop of Henle. So if you hear that, that is a common reference that people will make. So next segment is our collecting system. So this is not technically a part of the nephron, but it's the tubes that are going to carry the tubular fluid away from the nephron. And it's going to drain multiple nephrons. So you can see this one is draining the nephron we just saw on the last slide, but we've also got multiple nephrons draining here. These are in the renal pyramids, and they are in this like renal papilla, the papillary part. So you've got your papillary duct. This is another place to adjust water and solute reabsorption and composition of that tubular fluid. It's going to be critical in helping control hydration. The collecting duct cell-wise has two types of special cells. We're going to talk about those on the next slide. Again, it's going to collect fluid from many nephrons and carry that fluid through the renal medulla. The two main types of cells are the intercalated cells. So these cells have a specific role in secreting and reabsorbing hydrogen and bicarbonate ions. So intercalated cells controlling pH. Principal cells are going to help resorb water and secrete potassium. I don't know if it helps to remember that principal cells and potassium start with a P, but maybe that can help you keep some of those cell types straight. And then from the collecting duct, we're going to go to the papillary duct, and that's going to collect fluid from multiple collecting ducts and then take that fluid to the minor calyx. These are cuboidal to columnar in shape. They're not really doing anything to adjust the composition. They are just a conduit or a transport to get the fluid to that minor calyx. So we've put it all together one more time. We finished at our distal convoluted tubule. We came into our collecting duct where multiple nephrons drained. We did some solute resorption and secretion as well as water reabsorption. We moved into the papillary duct and then from here into the minor calyx. So what is the blood supply to the kidneys? How are we getting this blood here and where is it going? So it's going to come in the renal artery, and then it's going to go through these segmental arteries, which will split even further to be interlobar arteries. So these arteries are going between the lobes themselves. These will become arcuate arteries. Arcuate has to do with arches or arcs. And so you can see it does kind of arc around that renal pyramid. And then it's going to go into cortical radial arteries, radiate arteries. So here is your arcuate artery coming around to these cortical radiate arteries. They kind of radiate like sunshine, like the little lines around a kid's sunshine out of the renal pyramid. And then your glomerulus and your afferent arterioles, they almost hang off like little berries. This area. You're seeing here a cortical nephron, and here we've got a juxtamedullary nephron. And once it goes through those afferent arterioles, we're into the glomerulus. So here is our glomerulus from the afferent arteriole. Blood is going to leave through the smaller diameter efferent arteriole, and then it's going to move through these peritubular capillaries in a mesh-like net before draining to the cortical radiate vein. And this is super important because these vessels are intimately related to this nephron loop. And this is what allows things to get absorbed, secreted, reabsorbed in the area to obtain homeostasis in the blood. We talked about the efferent arteriole is smaller in diameter than the afferent arteriole to increase pressure to allow that filtration to happen. So this is a really nice little overview of the anatomy. It also is a helpful part where if you wanted to print out this slide or use the slide, the image in your book and write down the specific physiology that's happening there, or even the type of cells that are there, it's a great image for that. So the urinary system is what is maintaining homeostasis. So it's regulating not only the volume of blood, but the composition of blood. And the goal is to concentrate the urine to 855 to 1355 milliosmoles per liter. So the big things we want to be excreting are metabolic wastes like urea. Urea comes from ammonia and the protein breakdown. We learned about that in the metabolism unit. We've got creatinine, which comes from muscle function, and then uric acid that comes from DNA breakdown or nucleic acid breakdown, because we do break down RNA as well. So this is showing you the difference between the blood plasma concentration and the urine concentration. And it's showing you, one, how much variation there is in the urine concentration, because that's going to change depending on what the body needs. And you can see that if your sodium should be between 135 and 145, if that sodium is low, you're going to have a pretty low amount in your urine because you're going to be keeping it in the body. However, if you just ate a bunch of French fries with extra salt, your sodium is going to be really high, and so you're going to lose more of that sodium in the urine. Potassium is a big one. Potassium levels are normally 3.5 to 5, and you can have 25 to 100 milliequivalents per liter concentration in the urine. And then we've got bicarbonate as well. This potassium becomes incredibly important in urinary blockage. So in cats, and in male cats especially, but I have seen it in dogs and female dogs, if they have a bladder stone that blocks them from urinating, they cannot excrete potassium. And so the potassium ends up staying in the blood. The body's trying to filter that out and excrete it, but there's nowhere for it to go. And so you will actually see, I think the highest potassium I ever saw was up like near to 10.5. But as potassium goes up, the heart rate goes down, the EKG changes, and you can end up in cardiac arrest. And so that's a pretty serious thing, and actually more life-threatening in animals than the thought that like the bladder might rupture. The bladder can for sure rupture, but usually you're going to have problems with your potassium before that happens. So goal in that case is to make sure that we remove that stone or the mucus or whatever's blocking the area, and then try and help rehydrate the patient and bring that potassium down however we can to put it in a safe range. When we look at the metabolites and nutrients, we have a specific plasma level, but the urine level is pretty constant, and there's not really a range there. It's the amount that the body is able to get rid of, and it's not really things you're wanting to get rid of. Those are things that are precious, and so you're going to try and keep them to low levels in the urine. If it's high, then we get worried. And then you've got lots of different nitrogenous wastes. You've got your urea that comes from the ammonia. Notice that there is a very low ammonia level in the plasma. There's a higher level in the urine. But if we can convert ammonia to urea, we can have a little bit more in the blood, but we can have a lot that leaves in the urine. I think those are the big things for us to be aware of in urine homeostasis. So we're going to transition into talking about renal physiology. So this is how does this process work to get us the concentrations we want in the blood and to allow things to leave in the urine? And there's three big processes. So the first one is filtration, and this happens when you've got lots of blood pressure. It's going to push water and solutes across the membrane of those glomerular capillaries into the intercapsular space. So think about this as being the glomerular capillary. You've got a lot of pressure. It's going to push the water and solutes through this filtration membrane to create the filtrate in that intercapsular space. We've got resorption. This is transport of water and solutes from the tubular fluid across the tubular epithelium and then into the peritubular fluid. So not directly back into the vessels, but into the fluid around the tubules. And it's going to use a transport protein like we see here. This occurs when there's things we don't want to lose. We want to have a way to kind of quality control and pull back the things that we really don't want to lose. And then from that peritubular fluid, they can return to the blood supply if they're needed. And notice we've got a big note. The diagram is showing the arrows in the wrong way. We've got an image here that is correct, that's showing secretion. Secretion is going from the peritubular fluid across the tubular epithelium into the tubular fluid. So some things didn't go out in the filtration process due to size, due to whatever reason. We still want to get rid of them. We are going to secrete those into that tubular fluid. So quick review for us. What have we learned? Nephrons have two main parts, the renal corpuscle and the renal tubule. The corpuscle is made of the glomerulus, which is the capillaries themselves, and the capsule around them. And the renal tubule has several parts. It's got the proximal convoluted tubule. These are cuboidal cells with that microvilli border. We're doing a lot of reabsorption here, so we need surface area, and we also need lots of mitochondria to actively transport those molecules so that we can keep the things that we want. We have the thick and the thin limbs of the nephron loop. The thin limb is going to be more responsible for water diffusion, that's osmosis, and the thick limb is going to help us actively transport salts and other solutes. Your distal convoluted tubules, these are variable if they're doing reabsorption or secretion. They're kind of adjust to as needed, depending on how things are looking in the tubular fluid. And then your collecting ducts are going to drain your urine to your renal pelvis, then to your ureter, then to your bladder, then to the urethra, and then to the world, or the toilet. I guess that would be more accurate. So glomerular filtration, that is 180 liters per day. That is a lot. And it occurs when blood enters that afferent arteriole and exits the efferent arteriole. And again, that afferent arteriole has a larger diameter than the efferent arteriole. The pressure is going to be increased, and that's going to push that fluid through those membranes to drive filtration. And through the membranes, we're going to talk about those membranes. Water and small molecules can pass through the endothelial cells into the capsular space, and that's where it becomes called filtrate. But there are some things like glucose that pass through size-wise and charge-wise and everything-wise, but we really didn't want to lose them. So we're going to do a separate step and reabsorb them. And so that's what the nephron is doing, is we reabsorb 99% of the water, glucose, and sodium that are in the system. So again, formed elements, so that would be your blood cells, your platelets, and proteins should not pass through the filtrate. If they do, something is wrong, but you will see glucose in that area. So the nephron, after the glomerulus, the goal of the renal tubule is to reabsorb what went through the glomerulus and secrete what needs to be secreted that didn't go through it. And as we go through here, just note everything here that happens is related to osmosis, diffusion, or some kind of active transport. And so it's good to be aware of how are we creating gradients for these things to move and to obtain our goals. In this case, the gradient is created from the pressure. So the pressure is what is allowing the things, certain things to be moved onward as tubular fluid and certain things to stay in the body. So we have here our renal corpuscle. One of the big things we want to look at is the membrane. So the filtration membrane is right here, and it's made of a couple of things. We've got the capillary lumen, where our blood is, and we have fenestrated capillary endothelium. So simple squamous with these very particular pores. We have a basement membrane, and this is a little bit of a modified basement membrane. And then it is going to go through these foot processes. And these foot processes are specific to a cell called a podocyte. And when they go through these little filtration slits between the foot processes, it will become the tubular fluid. The basement membrane is a special dense layer, and it can encircle more than one capillary. So it's not necessarily particular to each individual capillary. And we'll see here the blood coming in the afferent arteriole. Here we're having the filtration occur, and all of that filtrate, which will become tubular fluid, is being released into this capsular space before it will enter the initial segment of the renal tubule. Here is that capsular outer layer, and then there is a visceral layer, and that capsular visceral layer is part of these foot processes and slits that things can pass through. Notice here we have some cells called juxtaglomerular cells. Their name tells you juxta, meaning nearby, like juxtaposition, glomerular cells near the glomerulus. And these are really important because they're going to secrete renin. We're going to have a whole little hormone section for this unit, but secretion of renin is going to be something that we talk about. So once we finish in the renal corpuscle, and we've gone through the glomerulus and that glomerular membrane, we're going to come to the proximal convoluted tubule. And there are two ways that we're going to move sodium here. We can move it in symport. So symport meaning glucose or amino acids that might have gotten through are going to be reabsorbed. And so the sodium will just kind of go along with them, or antiport. And in that case, we're going to switch sodium for hydrogen. And again, the goal of that is to keep the sodium in the body, to not let it continue in that tubular fluid. And if you move sodium, then there are things that go with it. And so watching the movement of sodium through this process will help you know some other things that are happening. So chloride always goes with sodium. Charge-wise, we've got to keep things neutral. So if you move some sodium, you're going to move some chloride. And then you're also going to move some water. So water occurs, the movement occurs through osmosis, and specifically these channels called aquaporins, aqua meaning water, pore meaning hole, they're always open. But as the sodium is pumped out of the tubular fluid, and into the blood, the osmolarity of the blood's going to increase. And because the blood has become more concentrated with sodium, there's some water that's going to follow. And so that's one of the main ways that we are able to maintain water and keep water in the system. So here is our proximal convoluted tubule. This is a place where reabsorption predominates. Notice how much is blue for water reabsorption, and for solute reabsorption, there's not really tons of secretion going on. We want to be aware that it's going to absorb 99% of our glucose, of our amino acids, and of our other solutes, as well as sodium, potassium, and bicarbonate. You can see, remember, those proximal convoluted tubular cells have microvilli to help with this reabsorption process. We've got a couple of ways we're seeing things move. So our glucose and other solutes are being resorbed, and some of those right here are being transferred in symport with the sodium. So the sodium's following the glucose and the solutes. We have some sodium that's being exchanged with these hydrogen ions to help with pH control. And then there is some here, if we need to, that can be exchanged with potassium. We're not talking as much about this particular pump in this unit. And we've also got some changes occurring to help with pH, moving bicarbonate along with sodium. And as all of this sodium comes into the peritubular capillary, the water is going to follow. This brings us to diabetes mellitus. So diabetes mellitus occurs when there is glucose being lost in the urine. So the liver normally converts glucose to glycogen. And if the liver can't make that conversion, then there's going to be too much glucose in the filtrate for the carrier molecule to reabsorb. So you need insulin to tell the cells to, come on, everybody take in that glucose, get it out of the bloodstream. In diabetes, either there's not enough insulin or you're insulin resistant. In that case, the glucose is just hanging out in the bloodstream. So it's going to be filtered through that glomerulus and that membrane, but it is going to be so much that those carrier molecules in the proximal convoluted tubule cannot reabsorb it. And so you are going to lose glucose in the urine, and it will test positive on the chem strip, but it will actually smell sweet, but the originally diagnosed diabetes by somebody tasted the urine and could taste the glucose in it, and that was part of how diabetes was diagnosed. This is way, way, way back when, but it's just showing you how much glucose was being lost. But not only is the glucose not getting resorbed, but the glucose is keeping the osmolarity in that filtrate and in that tubular fluid really high. So even though the body is absorbing sodium, there's not as much concentration gradient for the water to follow and be reabsorbed. So in this case, the water is staying in that filtrate and it's going to be passed in urine. So symptoms of diabetes are going to be increased urination because the kidneys can't hold that water. And then secondary to that is increased thirst. I think it's really common for people to think like, oh, they're drinking more and that's why they're urinating more, and this disease is causing them to be thirstier. But it's kind of in the opposite direction, because they absolutely can't keep the water in their body and it's coming out as urine. The body is always a little dehydrated, and so the thirst centers are firing saying, we're dehydrated, keep drinking. But no matter how much they drink or how much you drink, you can't maintain it with diabetes. And this brings up a great term. We talked about the term polyuria, which would mean increased urine production. So classic signs of diabetes mellitus are polyuria. And then the word for increased thirst is polydipsia. So you would have, patients come in polyuria and polydipsia with their urine smells really sweet. Again, we're not usually smelling urine. We're going to use a dipstick for it, but you do a dipstick and it's positive for glucose, and you know that this is diabetes mellitus. So we're back to the nephron loop. We didn't reabsorb everything we wanted in the proximal convoluted tubule, and the nephron loop is going to regulate the tonicity of the urine. So sodium chloride diffuses out of the thin limb passively, and then is actively transported out of the thick limb. And then water will leave the thin limb via a countercurrent exchange, so osmosis from the movement of salt, but it cannot exit the thick limb because there's no aquaporins. And then all the reabsorbed water will return into the blood. So it is passive out of the thin limb to reabsorb the water, and the water's coming along for a ride with the sodium. But the thick limb is a more active transport out, and it is just for solute reabsorption, not for water. So here we are at our nephron loop. What we're not yet. What we're seeing is as we move down the descending thin loop, we are having water reabsorbed. It's moving from an area that has a low concentration, from an area with a low concentration to an area with a high concentration. And then as we come to this ascending thick loop, we are actively transporting out solutes. And what is really cool about this is by actively transporting out solutes, and you have to imagine there's tons of nephrons all around this one, then we're going to keep that concentration gradient going so that we can have even more water diffuse out of that thin loop. So it is creating the concentration gradient that is going to reabsorb the water. And that's why you have this really unique shape to allow this function of active reabsorption to permit this function of passive osmosis of water to occur. When we look at a little bit closer, we have our tubular fluid here and our peritubular fluid. We are reabsorbing the sodium, we're reabsorbing some chloride and some potassium, and then we resecrete that potassium because we don't want our internal potassium to be too high. And as we look here, this is showing us the osmolarity of what we're seeing and how that is working. So in the thin loop, we're permeable to water, we're impermeable to solutes, and that solute concentration increases. So we're seeing it's going from 300 to 900, and then we're going to come to this thick ascending limb. Now it is impermeable to water, selectively permeable to sodium and chloride, and so we're going to actively pump out that sodium and chloride. The solute concentration is going to decrease. But with that, we've retained some of the ions that we want to keep, and we've also retained some water. Really cool clinical correlation for this is a condition called medullary washout, and it occurs in humans and animals. The most recent case that I could see was from or the most remarkable recent case was from a human who had some neurologic disease, and that left her having some kidney dysfunction as well as having some thirst regulation dysfunction. And so in medullary washout, the patient is consuming way too much water. And they said at one point, this lady was consuming like 40 liters a day. And at the beginning, it's usually because of some kind of neurologic dysfunction. It can be something like diabetes insipidus or something hormonal. In dogs, there are some dogs that are so stressed, their stress relief mechanism is to have like this psychologic excessive drinking. And over time, you will drink so much water that you will actually begin to lose this concentration gradient. And so you will called washout because you wash out these solutes from the renal medulla. And without those solutes, you can't retain water. So what started as, I was having some kind of excessive fluid intake for some reason, has now developed into there's actually no way I can physically keep water inside the body because there is no concentration gradient to maintain it. And so in those cases, you have to manage the fluid, the amount that you're giving, the time that you're giving it, and the composition of those fluids, so that gradually you are able to rebuild the solutes in that medulla to help attract the water to them. So a really neat example of how those solutes are what keep water in. When we don't have those solutes, then we can't keep water in the body, and it's just going to go out in the urine. So the distal convoluted tubule is responsible for secretion and reabsorption. And what happens is regulated by hormones. So we only have 10 to 15% of the original filtrate by this stage in that distal convoluted tubule. And hormones play a big role. So we're going to change the color and have a little hormonal interlude. This is something that in clinical practice came back to haunt me over and over and over again because it deals with such critical common systems. So that's why I've put it in a different color to try and get it to stick better in our minds. And because as doctors, nurses, technicians, dental hygienists, this is where a lot of blood pressure medications are working. And we have so many people with hypertension on those medications. So the big hormone to think about in this case is aldosterone. And aldosterone comes from the adrenal glands. And the goal of aldosterone is to promote potassium excretion and promote absorption of sodium. So get rid of potassium, keep sodium in, and then hopefully keep some water in. And it acts specifically at the distal convoluted tubules. So if you're keeping the sodium in, you've got a couple of things that are going to happen. One, aldosterone will directly cause more fluid consumption. And then with that sodium, it's going to increase fluid retention from the kidneys. And it's also going to cause the veins systemically to constrict. And that's going to give you increased blood volume and increased blood pressure. And that's going to increase the blood flow to the kidneys, which is negative feedback to shut off the aldosterone production. So what started the aldosterone production was the hormone renin. Renin secretes or triggers the release of aldosterone from those adrenal glands when the blood pressure is low or the blood volume is low. And renin came from those juxtaglomerular cells we saw. So renin triggers the release of aldosterone. Aldosterone encourages sodium to be lost, potassium to be kept, which is going to also keep fluid in the body, increase blood pressure, increase blood volume. The blood flow to the kidneys is going to increase, and then that's going to stop the renin production system. So keep that in mind because there are other hormones that will play a role. So we have hormones like atrial natriuretic hormone. This hormone comes when the atria are stretched. If your atria are stretched in your heart, that's because you have too much blood volume. And so what's one way to get rid of blood volume is to inhibit renin. If you inhibit renin, you're not going to be reabsorbing as much water. You're going to have increased water output, and that's going to decrease the blood volume and hopefully reduce that stress. We've got the hormone angiotensin 2, and this hormone leads to aldosterone. And this is a really complex pathway that involves multiple organ systems. I'm not expecting you to know all the organ systems, but just know that renin is released. We have this pathway of cleaving and activating, and we end up with these angiotensin converting enzymes. They're known as ACE. That's going to make the angiotensin 2, which is going to release aldosterone. And the reason I mention this is we use ACE inhibitors. So if you've heard enalapril, benazepril, all of those pril drugs, I guess not all of them, but many of the pril drugs to lower blood volume and blood pressure. So the ACE inhibitor is going to not allow angiotensin 2 to be made. We're not going to be able to make as much aldosterone. We're not going to be able to keep as much water in the system. It's going to lower the blood volume and the blood pressure. And then we've got antidiuretic hormone. This hormone acts in the distal convoluting tubule, and it is triggered when the hypothalamus sees that the blood osmolarity is high. So if we don't have enough water, we're dehydrated, things get too concentrated, it's going to release this hormone, and it's going to say, hey, continue to reabsorb water. The nice thing is its name kind of tells you what it does. A diuretic is a drug that causes you to increase more. Many people will call it their water pill. So things like Lasix are diuretics. And so when you take Lasix, you're just going to have to pee a lot, and that's how you're getting rid of the fluid. So if you have something that is antidiuretic, that means you're going to pee less, you're going to have more water being reabsorbed into the system. I do want to share, I'm going to go back. This is your fun little thing for today. Aldosterone plays a role in Addison's disease. And I don't know if you remember, we talked about Arthur the poodle back in the endocrine chapter with Addison's disease. And the lack of cortisol, but Addison's disease can also be a lack of aldosterone. And there's a little song that is how I remember Addison's disease, and you only get to sing the song if you have an Addisonian patient, but because we're talking about it today, you do get the song. And that is one way I remember what aldosterone does, is I remember the song, and then I remember that there's no aldosterone in Cushing's disease, so do the opposite of the song. So the song is, high potassium, low sodium, you must be an Addisonian. Thank you very much. I'm not a singer. There's a reason that's not what I do, but when you don't have aldosterone, you have a high potassium and a low sodium. When you do have aldosterone, you are losing potassium and you're absorbing sodium. So those are all our little hormonal interludes that we're going through. And here we are at that distal convoluted tubule. So at this stage, we're having our sodium reabsorbed. We're having our potassium is being excreted into that tubular fluid, secreted into that tubular fluid with our aldosterone. We're also having some hydrogen exchange with sodium if we need to adjust the pH of our blood. And then we've got carrier proteins here that are going to secrete toxins and drugs. Big use for kidneys is medications that are metabolized by the kidneys. You have to calculate a change in dose. And so depending on the patient, the drug, the values of those kidney numbers, you may have to cut the dose by 20%, by 40%, or you maybe shouldn't use the drug at all. Because if your kidney tubules aren't working well, how are you going to get those toxins and drugs secreted? And are they just going to build up in the system to dangerous levels? So here we are in the collecting duct. We have aquaporins here that are closed unless ADH is present. That's that antidiuretic hormone. If you have antidiuretic hormone, those pores are going to be open, and that concentration gradient in the renal medulla that's there is going to encourage the water to leave. To try and keep water in the body so water can osmose back into the blood. So we're seeing here a little bit following the movement of water and the solute concentration. It gives you a great opportunity to see, one, how it varies from the cortex to the deep medulla, where we are relatively unconcentrated to very concentrated, and how we use that to encourage movement of water and other molecules. Urea is a molecule that at this collecting duct, it becomes permeable, and then it is able to move out as needed through these permeable channels. So the descending limb, permeable to water, impermeable to solutes. Ascending thick limb, impermeable to water, but permeable to solutes. You can get some solutes out of here. And we saw that. Let me go back so you can see it here. That wasn't the place, but here you go. Here's that solute reabsorption happening at that area. It's not really represented well here, but it's happening. You've got here, we're moving into the collecting duct where we've got water being absorbed if we need to and have the help of ADH. And then we are having urea reabsorption here where the papillary duct is permeable to it. And it's going to be in this deep part of the medulla, providing even more encouragement for water to follow and be conserved. So a few helpful tips and tricks and things to have in your back pocket. This is on page 945 of your textbook, but a really nice image of the cell types of the different parts of the renal system, the order that they occur, and what is happening in them. So a great opportunity to look at that. And then this image is on page 956 to 957. It is a massive overview of everything that's happening. So it may be worth spending some time going through it step by step, and you can notate what's happening on it or notate the cell types. Again, it is a helpful tool to have. Few clinical correlations. One is kidney failure or renal failure. So if you have renal failure, your kidneys can't filter the waste and maintain homeostasis. And so you have a buildup of toxins in the blood. You have a buildup of waste products. You also can't control blood pH as well. And you can't control your electrolyte balance as well. And there's two types of kidney failure. So you've got chronic versus acute. So acute happens when there is a really sudden injury that happens. So this is the sort of thing, if you overdose on a drug, that's going to cause kidney failure. That is acute. Big causes in animals, in cats especially, are eating lilies. So your Easter lilies, don't put them with your cats. It will cause severe acute renal failure that is difficult to recover from. So it happens suddenly, and it's really severe. But if you're able to keep the patient going through that period, because at that period, the kidneys aren't going to be able to do anything, then you may be able to regain function over time and have a little bit of a better prognosis. It just depends. And so this is a place in animals and humans, you can go into hemodialysis that we're going to talk about to remove those toxins, support the kidneys while they're not working, and hope that they can regain some of that function. On the other hand, chronic kidney failure or renal failure happens over extended periods of time, and it is not reversible. And over time, the wastes and the toxins build up, and they can make you feel pretty puny. One of my mentors used to describe kidney failure for dogs and cats like being hungover all the time because you are dehydrated. You feel tired, you have a bunch of waste in your system, your electrolytes aren't balanced, you feel awful. In humans, we have the option to do hemodialysis. So hemodialysis is where we remove the blood, we run it through a machine using an artificial membrane, and it's going to do the filtration for us and remove everything that we don't need for us, and then put that blood back in the body. And usually you're going about twice a week. And it's long term, because once you have chronic kidney failure, those nephrons don't come back. The only option to get off of hemodialysis is with a kidney transplant. And with a kidney transplant, you need a donor that's going to be compatible, and then you're also going to be immunosuppressed to prevent rejection of the organ. Interesting little side note, they do offer kidney transplants for kitty cats because it's very prone, again, to get renal failure. And the last time I heard, it was at North Carolina, NC State, and you would take your kitty cat, you would go, they would have a donor that matched from the animal shelter, donate its kidney, and then you would take your cat and the donor cat home and give the donor cat a lovely life with your cat and its new kidneys. So I think that's pretty cute, and a really big deal that they offer it. There are some other clinical correlations. We've mentioned a little bit kidney stones. This is buildup of minerals, whether it's calcium or magnesium. I think some of it is dependent on diet, water consumption, and then individual metabolism. And those can become lodged, whether that's in the ureter or the urethra. And many times, they can use a little laser or like not even a laser, but even sound waves to try and break up that stone to help it pass. But there are some times when they're not able to. And my understanding it is one of the most painful things that can occur. And we have urinary tract infections, which are when bacteria travel up the urethra into the urinary bladder, causing infection and inflammation. And in that case, you're going to see the dysuria or the painful urination that we talked about. I do want to go back one more time to the chronic disease because there are some things diet-wise that you can do, and it's really interesting to see those in relationship to what we've talked about. So in humans, the goal is to restrict water, salt, and protein because these are the things that cause the kidneys to do the most work. If you have too much salt, your kidneys are going to have to adjust those levels. They're going to have to try and figure out how to resorb water. And how to not resorb water if you're drinking too much. And then they're going to have a lot of waste to process with the proteins because the proteins make that nitrogenous waste and that urea. And so that is one of the treatments for chronic kidney failure in people. It's very different in animals. If you've got a pet and kidney failure, talk to your vet. A few little random bits of interest. Number one, urine isn't sterile. It has lots of bacteria, usually harmless. There's always some healthy bacteria, especially in like that urethral opening. We just don't want a lot going up there, and we don't want the wrong ones going up there. This is a huge deal. So as you go through your training, keep your ears open because it is a big debate as to when do you test people for urinary tract infections and when do you treat them? Because some people say, well, you should just test them every so often, and then every time there is one, treat it. But then there are people that are also saying, well, this is causing a lot of antibiotic resistance, and now we are having urinary infections that we can't treat. So maybe we should only treat the ones that are symptomatic instead of looking for infections to just treat them. So that is a really hot area of interest and of clinical guideline development. Cranberry juice, it does not treat UTIs. It doesn't cure them, but it will reduce urinary tract infections, specifically from E. coli. E. coli have these little fimbriae, like little arms that would adhere to the bladder surface, and the cranberry juice or any kind of cranberry extract makes it harder for them to attach. But if you have a UTI, the cranberry juice is not going to fix it. I mean, if you drink enough, it may like dilute out some of the bacteria, and then they're just going to keep growing. So talk to your doctor. We can grow urinary bladders in a lab from a patient's own cells, and that is a way to relieve incontinence and reduce kidney damage from really high pressures. So neat to know that we are growing cells. And then my favorite fact, I don't know why it's my favorite fact, but I think it's so cool because it explains a lot about the world, is alcohol blocks antidiuretic hormone. So if you block antidiuretic hormone, you're going to end up with a diuretic. And that's why when people drink a lot of alcohol, it creates the need to urinate a lot. And that inability to resorb water, kind of like we talked about in diabetes, is going to lead to dehydration. Which, when you wake up the next morning, or when the person wakes up the next morning, they are really dehydrated, and that's a huge contributor to a hangover. So drinking can be really helpful to help combat those effects. And then caffeine is going to speed up your glomerular filtration rate. So you're going to have more pressure there. You're going to be pushing more fluid into that tubular fluid or that filtrate. It's going to reduce sodium reabsorption. And so there is the potential as well for that to lead to increased urination and dehydration to go with it. Though I hear various things about, is your coffee helping you keep hydrated? I'd say at this stage, stick with your water. This is it for the urinary system, and I will see you for the next time. Thanks so much. Bye-bye.